I want to say, first of all, thank you so much to CF Ireland for bringing me here from Miami over to Ireland. And thank you so much for allowing me to be part of this journey. I've been doing clinical research in CF since I was a doctoral student in Canada in the late 1980s. And so I've really been on this journey for over 32 years and never dreamed that we would see the advances that we are seeing now. When I first began working on a CF team in my graduate training, we didn't really have any adults. Maybe we had a few people in their 20s. And so to have seen this change in lifespan and to see this remarkable era of modulators and the transformations that our patients and our clinics are making it's truly remarkable. It's really been an honor to be part of this journey. So I want to also thank Professor Gallagher for setting me up so beautifully for this talk, because he talked about clinical psychologists and how important they are, what an important member of the team they are. And so that's really appropriate for me because I'm a clinical psychologist and epidemiologist, and lots of what I'm going to talk about today would benefit from having a clinical psychologist or mental health specialist on your team. So I'm talking about new opportunities in the era of CFTR modulation. And the big ones I think here, and also Ed really hinted at those as well, is improving adherence. Adherence has been such a challenge in CF, and the usual prescribed treatment regimen have been so burdensome. And we're now at a point where we have an opportunity to reduce that burden. And also changes in mental health and the importance of mental health in this era of modulation. These are my disclosures. And so I really want to talk to you about what we've accomplished in terms of adherence. We think of adherence as one of the toughest nuts to crack. It's really hard to do this treatment regimen, to do it day in and day out. And we've learned a lot about adherence over the last 10 years. First of all, why adherence is so important. It is the single cause of treatment failure. And so improving adherence will directly improve health outcomes. The scope of the problem, we now have ways to measure adherence, and I'm going to show you some data today. We have electronic MEMS caps, we have medication possession ratios, we have much better ways of measuring adherence than asking people with CF, who often say, yes, I'm doing all my treatments, even though we probably know that they're not. And factors that influence adherence, what drives, what improves adherence behaviors, what makes it more challenging, how to improve adherence behaviors. We now have several trials that show us that we can actually improve adherence and change behavior, and new tools for assessment and intervention. So how will this change? What I'm really hoping for in the next 10 years is that we really see a reduction in treatment burden. And Ed presented some of those slides. We're already seeing some changes in treatment burden as some people are dropping off things like hypertonic saline or DNAs. And we have to think about whether that's safe, whether we have the evidence. So the costs of poor adherence are really phenomenal. And I can get this cost data from the US where we monitor costs. And we're wasting, this is across disease, it's not just CF, but we're wasting about $600 billion a year in the US healthcare system just on people not taking their treatments or not taking it as prescribed. Now, in the CF world, really, it's seen as highly burdensome. The treatment regimen that we've been prescribing for CF for decades is seen as very burdensome, and it is related directly to depression. So more burden is related to more symptoms of depression. So one of the things we can think about in this era of modulation is stopping some of these prescribed treatments. And Ed gave you some of the data. In the simplified trial, we know that it was pretty safe because you have very good lung function. It's only a 6-week study, but that you could either stay on your Dornase alpha and give up your hypertonic or vice versa. And so that's preliminary data, but people are starting to sort of drop off of those medications on their own and seeing how they're feeling. We also know that this UK STORM study is randomizing people to stop both hypertonic and DNAs or stay on both, and we're waiting for them to report out their results. So there is a sense here that we have an opportunity to reduce the burden of treatment. And what I'd like to really emphasize today is personalizing treatment, personalizing the prescriptions for an individual with CF based on their microbiology, based on their lung function, based on their past history. rather giving sort of one prescription for all, one size fits all, personalizing that prescription and personalizing medicine for that individual. So I want to really talk to you, and this is Barry Plant lent me these slides from court, and it was really kind of him to do that. And I think it's a really important point. This is the mean duration. These are people on ivacaftor and cork, and it's self-reported adherence. And if you look at the blue bars, that's pre, and the red bars are post. And just look at the colimycin colibri not taking after they've been on ivacaftor. Many more people were not taking their inhaled antibiotics. And Ed made that point really beautifully, and these data suggest that that's an issue. This is also tobramycin, the frequency of use. Again, those red bars not taking went up after going on Trio. And what you see up here is that by the Leeds criteria, those people, some of those people still have Pseudomonas. So I think that's what you really want to balance when you think about stopping or going off some treatments, is what is your profile? What are your current health status? And does your clinician, can you have a discussion about whether it's really safe to reduce some of those treatments? And I'd say the data show here, inhaled antibiotics would not be a good candidate for reduction, but maybe things like hypertonic saline and DNAs. So how serious is this problem of adherence? And I've been studying this for about 20 years. And this is the largest study we've ever conducted, looking at medication possession ratio. So that's how often you pick up your medication from the pharmacy. And we're able to track that using prescription refill data on a national level. We had over 3,000 people with CF, ages 6 up through 75, and they've been on these medications more than a year, most likely, and their mean age is about 22. So here are all the pulmonary medications that we were able to monitor. And if you look here, Dornase alpha, all the way down to hypertonic saline, I've rank ordered these by their rate of adherence. So better adherence to Dornase alpha and the worst adherence to hypertonic saline. You see that's only 35%. So you're only doing it 35% of what is prescribed. And then overall, the composite is only about 43%. So all of the data that I've collected in adherence using different methods of measurement suggests that patients are doing about half of what's prescribed across the board. And this shows that in the pulmonary area, some are even below half of what's prescribed. This just shows you by age. So here are little 6 to 10-year-olds over here on the right side, up to those who are older adults. And you can see also that adherence declines with age. So there's better adherence in much younger children where parents are maybe supervising more, they're at home more. But as children move off into school and become adolescents, adherence decreases in adolescence. And I can tell you that that decrease doesn't recover in adulthood. They pretty much stay down low. So again, it's that below 50% rate of adherence overall. Here's the cost. And here we were able to calculate the cost by low medication possession ratio, meaning very poor adherence, up to good adherence, which is on your far right, high medication adherence. And you can see the cost difference. This is all costs, types of costs, hospital, outpatient. You can see 34,000 versus 54,000. Just to give you an idea that if you're adhering less to your medications and treatments, you're going to cost the health system much more. So what are some of the factors that drive adherence? Well, I'd like to start at the top, knowledge, really knowing how and when to take your medications. We always make this assumption that everybody knows everything and we're doing a great job with education on a CF team. And we do, and we try very hard to do a great job. But I asked like 118 adolescents, do you know what the best order to take your treatments in? And almost none of them could tell me the best order to do these treatments in, to get the best benefit. So there are still gaps in knowledge we need to remediate. In terms of skills, we have these adolescents from 18 centers bring all their equipment in, show their physio how they do their treatment with their nebulizer, how they clean the device, how they do their airway clearance. And I started getting phone calls from physios all over the US saying, oh my God, the tubing's broken, the device hasn't been cleaned, the vest doesn't fit this person anymore, and really they didn't have the skills to use the equipment for the maximum benefit. Treatment burden. I love this quote. There is a lack of understanding regarding treatment burden. It's a burden for a lifetime, and you can never have a day off. So that just gives you that sense of the impact of treatment burden on someone's everyday life. And in terms of mental health, that's also key in terms of depression. And if you are feeling depressed or down or discouraged, there's a direct relationship between those kinds of symptoms and doing fewer of your treatments. So if you are feeling depressed, you're much less likely to do those treatments every day. And then finally, I told you age and developmental stage. So we really see a high risk when kids go from school age into adolescence and drop their levels of adherence. I wanted to show you, this is, we did this huge research prioritization survey in mental health. We had 693 community members and 350 providers respond to the survey. I'm going to bring this up a little bit later as well, but I just wanted you to look at this rank ordering. Effects of treatment burden, it's number 3. It's one of the most important things for families, for people with CF, is to reduce this treatment burden. This also came out in a very important report in the UK. The treatment burden was, for families, one of their highest priorities to reduce this burden. So what does that burden look like? I mean, as you see on the left side of the slide, here's all these treatments we've been prescribing for a very long time: vitamins, enzymes, hypertonics, antibiotics, everything. And then on the other side are all the things that you want to do in your life. Do sports, go to school, play, have family time, recreation. It's just very hard to find that balance, to be able to do all the things that you want to do in your life and accomplish, at the same time managing all of these medications or treatments. And again, I just like to emphasize that the more burdensome these treatments are, the more likely that person is to endorse symptoms of depression. So I wanted to show you some of the data from the TIDE study. Some of you may know about this study. We screened depression and anxiety in 9 countries, over 6,000 people with CF, ages 6 up through 80, and also 4,200 caregivers. And so this is the largest mental health screening study ever done in any chronic disease. And we learned a lot about our mental health situation in CF. First of all, we showed that people with CF are 2 to 3 times higher in terms of rates of depression and anxiety than community samples. So having CF really does put you at risk for having challenges in mental health. And we need to validate that and really begin to address those issues, because they will help that person live and manage their CF much better every day. So 2 to 3 times higher. That was really shocking to people when we published these data, and really a call to action for ECFS, the European CF Society, and the CF Foundation in the US. We also recently published, we followed 1,000 adults with CF in the United States through our patient registry. And in the TIDE study, they were screened 1 time, and 1 single elevated depression screen, 1 time, led to a doubling of mortality within 5 years in the registry. Now, we don't know the exact cause of that, and we're doing some additional analyses. Maybe what we think is that if you're feeling depressed, you're less likely to do your treatment, and therefore you started to decline in terms of your health, and that led to your earlier mortality. I think this really highlights the fact that mental health is so important, and we've really had sort of a focus on physical health, which is completely understandable. CF has been a very difficult disease to treat and live with, but it's also important now to rebalance that and think about mental and physical health and addressing needs in both of those areas. I want to show you a study that I published on adherence to enzymes. I was telling a mom about this study last night. We always had this idea in CF that enzyme adherence is really good. First of all, it's an oral pill, not that hard to take. It's not like doing airway clearance. Second of all, you get a tummy ache or you have symptoms if you don't take your enzymes and you eat. So obviously adherence would be better, driven by those symptoms. We always had this idea that we don't need to really worry about adherence to enzymes. It's good. So I thought, you know what, it's all been self-report up to now. Let's do an electronic monitoring study. So we put these little caps, these MEMS caps on the enzyme bottles. We had bottles at school, at home. If families were divorced, we had them in both houses. And it electronically tells you every time that bottle's opened and enzymes are taken out. This is really it's really the only study that's measured adherence to enzymes electronically. And what we also, sorry, I should go back. I want to note here, 30% of these moms, 88 mothers at 3 CF centers, 30% were depressed above a clinical cutoff. So 1/3 of the moms were struggling with symptoms of depression. So then we looked at enzyme adherence in relation to depression, and what we found was that even mild symptoms of depression, you opened the bottle less, and being above the clinical cutoff, you were less adherent. So you gave your child enzymes less often if you were reporting symptoms of depression. And when we put this whole model together, what we found was actually that 3 months later, those children lost weight at their next clinic visit. So about 30% of moms were depressed. Caregiver depression was related to opening the bottle less often, and opening the bottle, giving enzymes less often, was associated with a decrease in weight. So again, just to show the impact of depression on adherence and disease management. It's real and it's significant. And so it's so important for us to address mental health, not only in people with CF, who are trying to be responsible and do their treatments each day, but caregivers. Caregivers face an enormous burden in managing this disease, and thinking about their mental health and well-being is really important. So when I think about adherence, I think about a multifaceted approach, that we need to give them a written treatment plan, they need to have knowledge and skills to manage their disease. It's important to identify the barrier. If you're not doing a treatment, what gets in the way? And then we do problem solving to address that barrier. So this is an example of one of the adherence barriers modules I've developed. This is just an example, a couple of items. We did all these qualitative interviews with providers, with people with CF, and we identified the key barriers for each treatment that's prescribed in CF. We have an adolescent and an adult version. So I wanted to take you through a problem-solving session, which is part of cognitive behavioral therapy. Very simple. We do these sessions in clinic. It takes about 8 minutes, and you can actually have an effective intervention for adherence. So we might say, let's say you're not taking your enzymes because you're going to a party with your friend. So really the simple question is, what's getting in the way? Which treatment are you willing to do more of? And then we do a problem solving with the parent, with a sibling, with a partner, with a spouse, and the provider. And it's really fun, think out of the box. So let me illustrate it with a really simple, this is a really good example. I do this with adolescents all the time. So my friends don't know I have CF, but I'm going to a pizza party, and you know what, I'm not gonna take my enzymes. I know I'm gonna have a really bad stomachache after, but they don't know I have CF, and I don't wanna tell them, so I'm just gonna skip my enzymes. So what's the barrier? Not wanting to tell people you have CF, not wanting them to notice. So then we begin to brainstorm, we use sticky notes, and the adolescent leads the session. Okay, what solution can I come up with? Well, I could go into the bathroom and take my enzymes. We write that on the sticky note, put it up. Mom says, well, you know, he could go outside and say he's making a phone call, take his enzymes privately, nobody knows. Provider says, well, you know, you could have them like in a little container and pop them in, and if someone asks you, say, oh, they're probiotics. You know, that's really good for my digestion, and you're taking your enzymes. So we problem solve, we go around the room 3 times, we get 9 solutions, then we vote plus or minus which solution is everyone willing to try, most importantly the adolescent. And so we usually get 3 or 4 solutions that get all plus votes. And in this one, he decided that he was gonna take a bottle of water and go outside, make a phone call, take his enzymes outside with water, and then come back into the pizza party, and nobody would ever know. So everybody had to implement the plan. The party was in 3 days. He picked the solution he was going to use, and mom helped by getting the bottle of water. So I want to show you an example of a study in Israel that used problem solving. They did it once each clinic visit, so just 4 times in a year. They did a problem solving session. This was in Israel, 21 adolescents, young adults, and you can see here they got significant improvements in taking their inhaled antibiotics, colniacin and Toby. The other things didn't change, but those 2 inhaled antibiotics, they improved their adherence just in those 4 brief problem-solving sessions. And then this is Martin Wildman's study from the UK. This is the largest adherence intervention study, 300 in the treatment group, 304 in the control group, 12 months, very intensive monitoring of medications. You had a dashboard, you could see what you refilled. Your providers could also see what you refilled and what you didn't refill. And it was a behavioral intervention. It focused on problem solving and data logging and viewing adherence. And so it was really an intensive study. So what did they find? They were hoping that they would see an improvement on IV-treated exacerbations. That was their endpoint. So I can tell you they did not find a significant difference in exacerbations or lung function or BMI. However, they did find a difference in taking your inhaled medications. You can see I put an arrow in the intervention group. That's their rate of taking their medications. And importantly to me, treatment burden improved. The group that had the intervention rated their treatment burden as less, and we saw no increases in anxiety, even though the provider was looking at your data with you as the person with CF. It didn't lead to anxiety. The discussions were conducted in a really supportive, positive way. So I'm a big believer in problem solving. I think it's a very simple, easy thing to incorporate into a clinic visit and improve adherence. So I wanted to show a little bit of the recovered data. This is exciting. I'm helping Sharon Sutton and Paul McNally working on this wonderful study you're doing in Ireland and the UK. And Sharon is a young, really eager researcher, and so I'm sort of mentoring her in the background. She gave me these slides. She presented them at the North American meeting. And if you look at these bars, the red bars are medication possession ratio, and the greenish bar is self-report. Remember what I told you about self-report? People say, oh yes, I'm taking everything. But the medication possession ratio shows a different story. So if we begin here with the modulator, what you see is really good adherence to the modulator, 80% on medication possession ratio. Of course, the patients are saying I'm doing 98%, so it's a little bit higher. But look at Dornase alpha, and what you see, those green bars, that the medication possession ratio in red for Dornase alpha, hypertonic, azithromycin, enzymes, all of these are much less than what we would hope, and much less than what they're reporting in the green bars. So as Ed suggested, people are starting to drop off their medications. They're starting to do less Dornase alpha, hypertonic. And so you have to be really thinking about what is it safe to drop off and what is my unique profile? What bacteria do I colonize? Do I have Pseudomonas? And it's really important for me to stay on my inhaled antibiotics. So we're in a flux right now. We're in a transition period. We don't have enough data to be able to say, you can safely stop this or safely stop that. We have some really good hints, and we know that the future is looking brighter with reducing treatment burden, but right now we're just in this period of needing more data to know what's safe. And then finally, we developed this staying on track intervention. This was developed with adults with CF in Canada, of just what kinds of tips help them to stay on track with their adherence. And here are my sort of key tips for improving adherence. Personalize and co-create the treatment plan with the person with CF, with parents of children. So not a one-size-fits-all, but personalize the prescription. Incorporate treatments into your daily schedule, make them a habit. Seek out support. It really helps if you're able to disclose to others that you have CF. You can get more support from teachers, romantic partners. Problem solve key barriers. And then finally, I like to talk about this one for mental health. Think about just a few times each day, take a moment to pause and think about a moment of joy that you've experienced. I do this with myself all the time, and I do this, with patients, with care teams, all over the place. So the idea here is that sometimes we don't notice these moments of joy that come into our life. And just to be more mindful of those and take a moment to enjoy that and reflect upon it can really increase your mood. So I was thinking about a moment of joy for myself. And I had a moment of joy last night. I was sitting at the dinner next to a mom of a young child with CF. And we were talking and learning about her life, and she's wonderful and amazing. And I realized how happy I was to sit next to this mom of a 3-year-old, knowing that she is going to have such a much easier journey, that her son will do so well. Sitting there thinking how I felt before when I sat and talked to mothers of young children, had such a sense of hope last night, so real for me, such a change in all these 30 years of of being in the CF world. So that was my moment of joy, and I took it upstairs to my bed with me, and it just improved my mood. So I'm going to talk now a little bit about mental health. Somehow the colors disappeared, but the idea here is there is no health without mental health. So in the center is your health and well-being, and around it is cystic fibrosis and both your physical and your mental health. So the first premise in doing this focus on mental health is that we have good measures, that our well-being includes both our physical and our mental health, that we need to treat the whole person. You're not just a set of lungs, a pancreas, a digestive system, you're a whole person. And the second is that we have good brief screening tools we can use. We recommend the PHQ-9 GAD-7, that it be done annually at every visit and then follow up if you're elevated. And also that if you have a chronic illness, or if you care for someone with a chronic illness, feelings of depression and anxiety are normal. They are a normal response to a challenging situation. And importantly, these feelings need to be validated. So we know about the impact of CF. We've been studying this forever. So CF, this chronic inflammation and infection, certainly leads to higher rates of depression and anxiety. I showed you the data from TIDE. It also affects adherence, and good adherence can also improve your mood. So that also goes back and forth. And then adherence, we know, affects your the possibility of having an exacerbation. So the other thing that this bidirectional arrows, this process, it influences clinic attendance. So if you're depressed, not feeling well, not up for it, you might be less likely to go to clinic. You may have more exacerbations. Your adherence is likely to be worse. I showed you that there's data that suggests that depression is related to earlier mortality. And finally, of course, it impacts your health-related quality of life. So mental health has a huge impact on your functioning and well-being. So now I'd like to take a moment and show you this incredible video of an adult, Andy Lippman, and about his journey with CF.
My name is Andy Lippman. I am 41, soon to be 42 years old. I am a husband to Andrea, a father to Avery and Ethan. I'm also a sports fanatic. I love baseball. I'm also a fundraiser, a motivational speaker, an author, and someone who just wants to beat cystic fibrosis. The biggest struggles I have, being that I have cystic fibrosis, it's not just the physical side, it's the emotional side. Dealing with the stress of having an infection, dealing with the stress of dealing with a life-shortening disease. When I was going through clinical depression, when I was initially diagnosed, one of the things I mentioned to the therapist, who said it was the exact definition, is I said I felt like I was in a well, and as I was climbing up, the well was getting deeper and the hole was getting smaller, and I just couldn't get there. And I always thought, this is a one-time thing and it's over. It's like a cold. You get it, you get rid of it, it's gone. But what I didn't realize, it never really leaves. It's always there, it's kind of hibernating. At first I dealt with it knowing the life expectancy of the disease. And then I dealt with it in college, wanting to be the same as everybody else, not so different. And then it's when you get married and you don't want to leave that person behind. And then it's when you have children and you don't want to leave them behind, and you want to see all their milestones in their lifetime. So going to get help was a big thing for me. And it was something that really worked out for my family and for me. I've learned as I've gotten older that going to therapy, that dealing with depression and anxiety is a part of who I am. And it's a part of fighting this disease. If you can't do that, if you can't go to therapy, if you can't get better, if you can't work on the mental side of it, then it's hard. It's difficult to fight this disease every day. I'm very fortunate to have the support system that I do. I have an amazing wife. I have great parents. I have a lot of friends around me that are always willing to help. And it'd be nice if you don't always have that, is that you have a doctor that can be there for you, that can listen to you, and that can find the help that you need. A CF patient, one of the biggest things we need, in my opinion, is motivation. And if you're not right up here, you can't have that motivation to do the things that we have to do on a daily basis.
So I think that's yeah, I love that video. He really normalizes the experience of depression. He's a fully functional, amazing guy. And apparently Caroline is in one of his books. She's famous. He's written up about her in one of his books. And he's doing well. But again, this emphasizes the importance of having a clinical psychologist, a mental health clinician in your CF center. It's really important. And one of the things we've done in the United States is that we've put a line item, the foundation's been able to put a small line item in there. So every single center has a mental health coordinator, either a social worker or a psychologist, who both does annual screening and screenings in between if elevated, and can provide interventions to address depression and anxiety. And that's the model that, of course, you're working toward in Ireland. It's exactly what Professor Gallagher mentioned. So anyway, I want to just go through this quickly. We did the TIDE study. I explained that to you. We went on to develop international guidelines for mental health for screening and treatment. And now we're in the dissemination implementation phase. So I showed you the TIDES. This is just a little bit about the TIDE study. And then we developed international guidelines. And the person I want to point out here is that Stuart Elmoyne was my co-chair. He is one of those people that I admire so much in the CF world. And it meant so much to me that I'm a clinical psychologist. So I chaired this international group, but he wanted to be the co-chair. And he lent such credibility and weight to these clinical guidelines on mental health that we established. So he's just an incredible colleague. Anyway, we worked for 2 years to develop these guidelines, huge multidisciplinary group of researchers, pharmacists, psychologists, pulmonologists, and spent 2 years identifying the best screening tools and then developing our guidelines. This is when we voted on the guidelines. And look, I put a little circle around Stuart. I don't know if you can see Stuart up there. But I mean, he's one of the most important people in my career. He's been such a mentor and such a great colleague to me. So I'm very proud to put this up there, and we all look like, we have like weird clothes and stuff back then. So I just want to mention that this is very simple. I'll go through it quickly, but here's the algorithm. Basically, you want to administer the PHQ-9 or GAD-7. It takes less than 5 minutes to do these screening tools. I have to say to Ed, like, I would not use the HADS. It's not a good tool. I've done huge studies showing it doesn't factor into the scales. So we really recommend the PHQ-9 GAD-7. If you're in the normal range, you just say, hey, you're doing really well. Anything you want to discuss? If you score in the mild range, it's just a supportive intervention. It's like, how are you doing? Anything I can help you with? Anything going on? Just check in, that's all. Now, if you're in the moderate or severe range, then we would recommend that you get some counseling, some evidence-based psychological intervention, or even medication. So there are new CF-specific mental health interventions that we've been developing in the United States, and I'm really excited to tell you, cognitive behavioral therapy is working so well to treat symptoms of depression and anxiety in people with CF. Most of these are delivered by telehealth, so you don't have to miss work or school. You can do it at a time that's convenient for you. You can have a CBT, cognitive behavioral therapy session online with your provider. People really love it. It's super convenient, no parking, no travel. And pilot studies, we have two really great interventions, CF-specific CBT and CALM, that I'm going to show you have produced wonderful results. So this is CF-CBT, and it's telephone or in person. And look at the effects. Those darker bars are large effect size, so big improvements in depression, in CF-specific coping skills, and medium effects in perceived stress, and small effect sizes in anxiety. So we saw improvements going from the top, depression, to anxiety in all of these domains after this study. And this is the CALM intervention, and you might notice the beautiful manual on the side that was drawn by a person with CF at National Jewish. And again, it's delivered via telehealth, and again, wonderful effects. So the large effect sizes, improvements in coping skills and anxiety and depression. So we are seeing incredible results. This is a 6-session intervention, very quick. Sessions are 45 minutes on the phone, telehealth, and really people loving them and getting great benefit. Both of those interventions are now in larger randomized controlled trials. So we're on to now dissemination and implementation. And we've developed a huge library of resources for patients and families. And I just gave all the information to both to Caroline and also to everyone here that they can download these handouts and use them with families and with people in clinic. I wanted to show you here that this is a study that was just accepted in pediatric pulmonology. We've been implementing now, tracking implementation of screening and intervention. And this shows from year 1 to 3 years, 138 CF centers in the United States implemented mental health screening and interventions. And we scored them on how good their implementation was. And this shows their improvement in implementation over 3 years. You can really see everybody, each cohort is getting better, and all of these CF centers are improving in implementing the mental health guidelines. This has been a huge success in the US. And so now every CF center has a mental health coordinator in the United States doing screening and intervention. So future directions. What are the top priorities for mental health in the next 5 years? And are there side effects we need to monitor with Kaftrio, and next steps for screening? So again, this is that slide of what the top priorities are. And I would mention it's depression, anxiety, reducing treatment burden, and what's next, effects of modulators on mental and physical health. So this has come out as a really important priority. This shows you the size of the bubble is how many people mentioned it. We coded over 3,000 snippets of qualitative interviews, and the highest ranked priorities were addressing mental health conditions. And this includes things like ADHD, substance misuse, body image, procedural anxiety and distress. So not just depression and anxiety, but expanding into other comorbidities linked to mental health. And that was a huge priority for people with CF and our community members. Screening, assessment, intervention, being able to live with CF, addressing system-level barriers, things like getting access to mental health, and then effects of modulators. People would like to know about these side effects. So these are some of the side effects that I have been reviewing the literature. There are case studies that have been reported, case series. There was just a recent case of 2 adolescents who tried to attempt suicide after beginning Kaftrio, who did not have a prior history of mental health problems. It was just published in Journal of CF. And although I don't think most people, that's kind of an extreme response, I think it's important to monitor this. These 2 adolescents have been doing fine in terms of their depression, anxiety, but really just after starting Kaftrio became very depressed, and it was really acute. So it's something so important to monitor and be aware of. So these are the kinds of effects. Some people experience increases in depression, some new onset depression or anxiety, cognitive fogging, problems with memory, confusion, word finding, just feeling like your mind is in a bit of like cotton wool or something, a little foggy. Increases in passive suicidal ideation, and Ed mentioned this as a concern. Negative body image. Some people in the US are gaining 20, 30 pounds within a couple of months. And so for some people, they experience that as too much weight gain, very rapid, they can't fit into their clothes, their body image has really changed as a result. Survivor's guilt. I mean, having been someone who now gets to go on Kaftrio, but thinking about all those who didn't benefit from that in the past, who may not have survived. So that's a real phenomenon that we are seeing in our CF centers. An identity crisis, like who am I? I associate myself as being a person with CF. A lot of my life revolves around that, my support system. And now it's like a lot of those symptoms are gone. I'm not coughing as much. I'm not doing all these treatments. Like, what about my identity, my self-concept? Like, we're really experiencing this huge shift. Imagine, this has been a very rapid shift. We just got Kaftrio in 2019. And in these years, these 2 or 3 years, we're seeing these very rapid shifts in self-concept and psychological functioning. For some people, they're disappointed with the benefits of treatment. I mean, some people don't respond phenomenally well. Most people do. Ed showed you the data, incredible changes in quality of life, improvement in lung function. But for some people, they don't benefit as much. Demoralization. I know you experienced this in a very intense way with the 35 children. But imagine if you didn't qualify, if you do have a genotype that isn't eligible for Kaftrio. think about how you would feel. That would be very demoralizing. I know several people like that in the US, and we're hoping that some N of 1 study will produce something that will be effective for them. Lack of future planning. You may not have really gone to university or planned a career or thought that you were going to have that long lifespan that you now have up in front of you. And then also fears of losing your CF community, the support people, like all the wonderful vibes in this room and the friendships over time that have been established. And then, you know, some of the physical effects, we see a lot of insomnia, sleep difficulties, insomnia, agitation, and some disordered eating and this rapid weight gain. And so in the States, again, we don't really know exactly what to do. We're experimenting, as Ed mentioned. Sometimes we flip the morning and evening dose, and that can be helpful. Sometimes we're reducing the dose, and that can be helpful. And then for some people, it's been really extreme side effects, and they've had to discontinue. And then we monitor them, and perhaps they can restart at some point. But I think the most important thing right now is for us to be aware of what these side effects might look like so that we can anticipate and monitor them and address them as soon as they happen. So I just want to thank you so much for inviting me to speak to you today, and this has been a wonderful meeting and conference. I'm impressed by how you've advocated in your country to establish these centers and individual patient rooms. I mean, the power of advocacy is just so clear in this room. And I want to thank my colleagues on the National Mental Health Advisory Committee, the investigators who did the TIDE study, which really brought mental health into the CF world, the CF Foundation for funding mental health coordinators, and really a huge thank you to the CF community. Thank you.